Okay, in this video, I am going to record my screen and I'm going to go over the anatomy of the knee. So I'm going to start with the bones, the ligaments, the meniscus, and then I'll do a second video about the muscles. So when we're talking about the bones that make up the knee, we have the femur, obviously, and then on the femur we have a couple bony landmarks that we need to remember. So if we think about the end of the femur on the medial side, this is called the medial femoral condyle. Okay, condyle just means a bump or a projection that allows muscles to attach to it. Then we have the lateral femoral condyle here. So when you do palpations, if you put the person in knee flexion, you can feel the ends of the femur above that squishy space. Okay. Then if we go down below, we have the tibia. We also have condyles on the tibia. So we have the medial tibial condyle here. We have the lateral tibial condyle here. And within those condyles, here is the pes and serine. And here is a bump that we call Gerdy's tubercle. Okay. And then right here where this attachment point is the tibial tuberosity. Then we have our fibula, and we have our fibular head, which is palpatable on the lateral side. So it's beneficial to you if you palpate the fibular head and Gerdy's tubercle at the same time, so you can figure out which is which. Fibular head is going to be more lateral. Gerdy's tubercle is going to be more anterior. Okay. Then we obviously have the patella. So those are the bones that make up the knee joint and their bony landmarks. So now I'm going to hide the patella so we can go through our ligaments. So we have 5 ligaments that we will learn in the knee. 2 of them are considered collateral ligaments, the MCL and the LCL. So we have the medial collateral ligament here, and it's obviously on the medial side, and it is going to be injured most of the time when the knee goes into a valgus position. Okay, so if somebody hits you directly on this side, lateral side, and makes your knee fall in, that's considered a valgus position. And that's how, like Nick Chubb's injured his MCL. And it's pretty common, especially in sports like football, where there's contact on the lateral side. Okay. On the opposite of that, we have the lateral collateral ligament, which is here. I can tap on them. There we go. So the lateral collateral ligament is less likely to get injured in a direct hit because we're protected by our other knee. However, if we go into a varus position, or we get hit on the medial side, pushing our knee outward, that's considered varus position, and we could injure our LCL that way. It's most commonly going to happen in sports like wrestling or Brazilian Jiu-Jitsu, mixed martial arts, because they get in weird positions where somebody can pull up on their leg and put them into a varus stress. Okay, one ligament that we didn't talk about injuries of, but is included in your anatomy, is the anterior lateral ligament. And that one just is recently getting a lot of press because surgeons are starting to repair it with an ACL tear, because it helps prevent some of the rotation like the ACL. If you notice, it kind of follows the same angle as the ACL does. So it does help prevent some of that rotation that the ACL prevents as well. Okay, so moving on, that is the anterior cruciate ligament. So it's deep inside of your knee. You would not be able to palpate it. You just know it sits inside the knee under the kneecap. So it's going to prevent the tibia from moving forward on the femur. It's commonly going to be sprain in a plant and cut maneuver, or a change of direction, or a deceleration, or landing badly from a jump. Again, going into that valgus knee position is dangerous for the ACL, and that's a common mechanism for tearing it. Okay, and then you can sort of see the PCL back there. You can get on it. Look at that. That is the posterior cruciate ligament. Obviously, it's more easily visible from the back when I turn it around, but it sits directly behind the PCL, the ACL, and it prevents the tibia from moving posterior on the femur. It's going to commonly be injured from a hyperextension or from getting hit directly in the tibia. If we get hit directly right here and it's pushed backwards, it's a common mechanism for tearing the PCL. So falling on a bent knee or having a dashboard hit your tibia is a common way for you to tear your PCL. Okay, it's not as common as tearing your ACL. Right now we have two cartilaginous structures that are shock absorbers in our knee, and they're called meniscus. You have a medial meniscus and a lateral meniscus. They're C-shaped. Let me hold that up for a second. Then we look down on top of them. So I removed the femur, and now if you look at the medial meniscus and the lateral meniscus, they're C-shaped. And their common mechanism of getting injured is from a twisting or a rotation, where the femur drives into the tibia and twists and kind of digs at that meniscus. And so we can get different kinds of tears, and the location of the tear kind of depends on how we handle the injury. So if it's in a red zone where we think it would heal, they would do a meniscal repair, and they would fix that. And then you'd be non-weight bearing for a while because it needs to heal. If it's in the white zone, which is usually going to be in this area here, the inside doesn't get good blood flow, so it's not going to heal well. So lots of times they'll just do a meniscectomy and they'll take a piece of that meniscus out. Okay, so those are the bones, the ligaments, and then obviously the meniscus of the knee.